Welcome back to Student Nurses Success, where we're focused on helping you succeed in nursing school and to be a great nurse. Today, we're completing part two of the white blood cell neoplastic disorders. Basically, we're going to talk about the 7 common leukemias and lymphomas. Remember, part one covered some basics with regard to leukemias and lymphomas, and this will give you the detail on the 7 disorders that I've chosen. Remember, you can find the link to the blank and completed maps in the comments section. So let's get started with our blank map here. And I've actually cut this into two to make it just a little bit easier for us. So this first chunk here we're going to actually look through is the red circles, which are the myeloid disorders. And these are the 2 myeloid disorders that we're going to actually talk about. So you can see they are red and they're called myeloid. The first one is CML, or chronic myeloid leukemia. Now, chronic myeloid leukemia is known as myeloproliferative, and that's an important term to remember. Myeloproliferative means there's too many functional cells. So the cancer part is that it's making too many cells, but the somewhat good news about CML is that the cells that it's making actually are functional, which is a little different with some of our cancers. The problem is we're making way too many of these cells, and so it actually starts to crowd out our other cells, such as our red blood cells, our other white blood cells, and our platelets. And so that's the problem. We're making too many of these white blood cells and it's crowding out. With CML, it tends to be a little more slower onset, maybe a little bit more insidious. And what we start to see is increased granulocyte count on our CBC. And those granulocytes just increase. And because they increase, they crowd out some of our other cells. Patients also often present with abdominal pain. Now, if you notice, I have like a little bell down here, and that's to represent the city of Philadelphia. One of the things about CML is that when they look at the cells, they will notice something called a Philadelphia chromosome. This is unique to CML, the Philadelphia chromosome. And so if we identify this chromosome, then we know that we have CML here. Onset for this is somewhere about 40 to 50 years of age. One thing about CML, although we're kind of lucky in that it is functional cells, the problem with CML is that it almost always turns into AML, which is the next thing we're going to talk about. And that's not actually as good. AML is acute myeloid leukemia, but it's myelodysplastic. And we see this dys in here, and that's never a good sign. So not only do we have too many cells, now we have too many abnormal cells. And that's a huge problem. So the difference here is this one is myelodysplastic, while the other one is myeloproliferative. These dysplastic cells are abnormal and they do not function. They also crowd out the other cells. So it takes up space and crowds out the good cells. About 80% are adult cases, and about 20% of the cells are in what we call the blast stage when AML presents. So we see about 80% of cases as adults, so the other 20% is children. And we know that it has an abrupt onset, and we know that it's AML when we see what's called blast cells are taking up about 20%. And blast cells are not good. Blast cells are those dysfunctional cells. Now, the prognosis with AML is not as good. It's a little bit more aggressive. And often the treatment for AML is a bone marrow transplant that we need to happen. And it would not be an allogenic, I'm sorry, it would not be an autologous, it would be an allogenic that is needed. Going into remission is much harder for AML. And so the treatment is usually a little bit more aggressive. The other symptoms that you'll see with AML is our pancytopenia that we talked about and bone pain. So it's a much more aggressive cancer. And those are our two myeloid disorders. So now let's talk about our, get it set here. There we go. Now let's talk about our lymphoid disorders. And those are all in the yellow circles. So these fall under the heading or category of lymphoid disorders. And in most cases, it's a problem with the B cells. And we know B cells are part of our lymphoid cells. So there's 5 of them that we're going to talk about. And the first one is CLL, or chronic lymphoid leukemia. Now, the thing about CLL is that it is actually a slower chronic onset, and we see it mostly in older adults, and it's often asymptomatic, so it's really not causing a ton of problems. And in fact, we know that survival is anywhere from 8 to 24 years. So if you're already 70 when you contract it, we actually may not do much as in the way of treatment if it's not an aggressive form. Again, most are B cell related. So it's the B cells that are not growing properly and they do not produce antibodies correctly. Make that a little bit bigger. There we go. And we know that just like in other things, it crowds out the good cells. And so we have got a little bit of an older gentleman up here to kind of help you remember that this tends to be more older adults. Now, ALL is acute lymphoblastic leukemia, and we see this mostly in children, actually. It's, in fact, one of the most common childhood cancers. And usually we see it somewhere about 3 to 7 years of age. So we've got a little kiddo down here to help you remember that. So again, with this one, it's mostly B cells that are kind of getting transformed and mutating and causing us the problem. And so what we have is an overproduction of blast cells, and blast cells are just poorly functioning cells. Now remember, if we're overproducing poorly functioning cells, that means it's crowding out our good cells. And so we see that pancytopenia set in again. So patients become anemic and bleeding and bruising and all of those symptoms. Other manifestations that you may see in children besides the pancytopenia is bone pain and limping. It's pretty common for kiddos to just start complaining of leg pain and limping. And you also may see lymphadenopathy or positive lymph nodes. Now, the good news about ALL is that it has a pretty good prognosis and is highly curable. Um, if by chance the patient has blasts that are found in their central nervous system, however, then that's going to reduce the prognosis and make it a lot harder to treat. Once those blast cells get into the central nervous system, we're going to have a harder time managing this. Now let's talk about multiple myeloma, also known as plasma cell myeloma. Plasma cell myeloma is slow, insidious onset, and usually somewhere around the age of 65 years of age, we start to see. What happens with multiple myeloma is we have excessive B lymphocyte antibodies being made. And they're in the bloodstream, but the problem is that they start to accumulate in the kidneys. And they actually will damage the kidneys. And that's actually what people may present with is they may present with kidney problems first off. What we will see is these things called Bence-Jones proteins in the urine. And those Bence-Jones proteins in the urine will lead to renal failure. Now, we also see that these B lymphocyte antibodies also can collect in the liver and damage the liver and even the lymph nodes. Some of the things that we see that are unique to multiple myeloma, besides the Bence-Jones proteins, is this frequent bone lesions, bone pain, and fractures. And so patients really experience a lot of bone pain with multiple myeloma. Now, up here, I drew a little kidney. And so that's to kind of help you remember those Bence-Jones proteins in the kidneys. Our second to last disorder is Hodgkin's lymphoma. Now, about 30% of lymphomas are Hodgkin's. And that's actually good news because the thing with Hodgkin's disease is that it has a very predictable course and spread. And this is good news because we know where Hodgkin's is going to go before it even goes there. And if we know how it's going to progress, we can actually treat it much better. We know that with Hodgkin's, one of the things that identifies it as Hodgkin's is the identification of something called Reed-Sternberg cells. So these B cells, when we biopsy them, we're actually going to see something called Reed-Sternberg cells. And if we see these Reed-Sternberg cells, then we know we have Hodgkin's lymphoma. And so that's going to be some good news because we have really good treatments for that and usually a really good prognosis. As far as the manifestations of Hodgkin's, usually the typical manifestations that you're going to see that we covered in our first video. In addition, you're going to have painless lymphadenopathy or enlarged lymph nodes, and usually the cervical lymph nodes are some of the first. You might have maybe some fever, malaise, and even some night sweats. They'll go ahead and biopsy that lymph node, find those Reed-Sternberg cells, and hopefully you'll have a great outcome. And so this guy right here, these are those cervical lymph nodes to help you kind of remember. Our last one we're going to talk about is non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma arises from B cells, T cells, or NK cells. Unfortunately, survival for non-Hodgkin's is not as good as Hodgkin's. And the reason being for this is often non-Hodgkin's has often already spread by the time we identify it. And remember, our name for spread is metastasized. We mostly see adults get on non-Hodgkin's, although I have seen my share of children have it as well. We know that the viruses HIV and Epstein-Barr increase the risk of it. And the other thing with non-Hodgkin's is a lot of times, um, as the um, as the cells proliferate and collect, in the lymph nodes, they actually may press on other structures. So, and these are not necessarily the cervical lymph nodes. These are lymph nodes deep in your body. So, if it's pressing, if these are kind of proliferating and kind of developing these large masses in the lymph nodes inside, like your thoracic cavity, it can actually press on your superior vena cava, causing, problems with blood pressure control. It can wrap around your esophagus. So it can press on your spinal cord and cause leg pain. So we start to see maybe some site specific symptoms and signs where it's pressing. And so these collections can get quite large. And so you might actually see some thoracic symptoms. Other symptoms include the lymphadenopathy, fever, night sweats, and weight loss. And again, prognosis isn't quite as good. And there you have it. Here's your completed map. Thank you for watching today, and remember to subscribe and like if you found our videos helpful. Now go ahead and get studying for that pathophysiology exam that I know is coming up.